Good evening, everyone. I'm Renee Brand. Welcome to our Code Lavender, not a typical code presentation. I'll be doing a brief introduction of myself and then I'll pass it over to Bree. She'll introduce herself and then we'll jump right into our presentation. Again, I'm Renee Brand. I've been a nurse going 12 years now, started out on an advanced med-surg ventrake step-down unit in New York. Dr. Master and I were talking about that. Stayed there for 8 years and then transitioned to cardiac telemetry. And I've been a cardiac nurse for the past 5 years. And now I'm at Piedmont Atlanta Hospital. I am currently pursuing my Master's of Science in Nursing at the North Central University. And Bree is my preceptor. And she's an awesome preceptor for my course that I am in now. And I will transition to Bree and she'll introduce herself.
Thank you, Renee. Thank you all for coming on a Friday evening, and it's 7 o'clock where I'm at. So
where we are,
yeah. So, but to me, there's no better way to spend my Friday evening. So, just to give you a little bit about my background, so I am currently the director of clinical and quality for a healthcare technology company called Matchwell. So we are a startup. We have been in the market for a little over 2 years, and we're in 11 states right now. And we help facilities get matched with clinicians that are looking for flex work. And the reason that Code Lavender, we just really attached ourselves to this idea because part of our company ethos is that we really believe that people should have work-life balance, and particularly healthcare workers and nurses. So I joined the team October of 2018, and I'm also a family nurse practitioner. So I still have my foot in the patient care world as well. And I grew up at a hospital called Northside in Atlanta and spent about 12 years working in women's health. And that's just a little bit about my background, and really excited to dive in and talk about Code Lavender tonight.
All right, we'll jump right into our presentation, everyone. Next slide, or objectives. So by the end of our presentation, we hope that you'll be able to define the framework for a Code Lavender program, and that you will identify the importance of a culture of care supported by Code Lavender. Hopefully, you'll also understand response recommendations and identify interventions included in a Code Lavender. Next slide, please, Bree. So as healthcare workers, we endure a great deal of stress throughout our work shifts, whether it's in acute care, home care, whatever setting it may be. And the culture is considered a stoic culture, and we're taught to carry on, to get through it, to forget about it. And it is this culture that has pushed some of us to a breaking point, almost to a point of no return emotionally sometimes, right? And most of us, whether we work in an acute care setting or not, we have experienced some emotionally charged scenarios, which have left us feeling like primary and secondary victims. So I'm going to read a scenario to you, and you may identify with it, but it's one of many scenarios which affect us as caregivers. Why am I crying? My patient survived. Everyone on the code team sang the nurse's praises for catching the early decline of my patient, who suddenly struggled to breathe, turned extremely pale, followed by the cascading occurrence of plummeting blood pressure and irregular pulses. The code team responded quickly, and my patient had a return of spontaneous circulation within 10 minutes. So why did it hit me so hard? An overwhelming wave of fatigue, guilt, and feeling unprepared engulfed me all at once. My patient load was heavy, and despite support and help from other nurses, I just couldn't catch up. Someone told me my patient was not feeling good earlier in the shift, but I did not have a chance to assess what that meant. I was of no help during the code, and I was immobilized by the fact that it was my first emergency. Can you identify with that? Is that something that you've experienced? Maybe something similar? An experience like that can leave us feeling lonely and emotionally drained. Such an experience is not an isolated incident, and there are numerous stressful events of varying degrees, which is reason Brie and I are happy to present to you the importance of Code Lavender. Next slide, please, Brie. So let's take a journey of Code Lavender. What is Code Lavender? It is defined as a crisis intervention strategy or an emotional cushion designed to provide an emotional rapid response and support to healthcare workers during times of high stress, a traumatic event, or a loss while on the job. And let's discuss the history of Code Lavender. So the first Code Lavender was implemented in 2004 by Dr. Earl Bakken, and he was a physician and board chairman of the North Hawaii Community Hospital in Waimea. He coined the term Code Lavender, and this was in response to the significant emotional decline he saw in his healthcare workers. And he believed that a deterioration in the emotional health of healthcare providers would contribute to the deterioration of patient care. And then he came up with something I personally think is brilliant. He proposed that his team utilize an integrative approach, 20% medicine and 80% holistic care. What he meant by that was a blended approach would yield the most optimal patient results. High-tech medicine being impersonal and straightforward just cannot reach the human. It just cannot provide that caring approach needed to achieve patient-centered care. And then 2008, the program was brought to light nationally by the world-renowned Cleveland Clinic, spearheaded by Dr. Brenda Duffy. And similarly, she saw where her nurses and physicians, they had this emotional decline, and this was due to compassion fatigue. And also the idea that she realized that they had lost the reason why they started healthcare in the first place, which is to heal. So Dr. Duffy, she believed that caring for all caregivers through programs like Code Lavender would help the individual reboot emotionally and help them achieve their immediate responsibilities and functioning. Next slide, please, Bree. Thank you. So how did Code Lavender become Code Lavender? So the code in the term was used to ensure the urgency of calling the response team, similar to activating an actual code. Now, it's not considered a true medical emergency, such as a code blue, but it is seen as equally important. It is considered an integrative healing equivalent to a code blue. And I think that's just brilliant. The lavender part of it comes from the lavender plant, which we all know has healing properties. It's known for its calming, relaxing, and anxiety reducing effect. We know lavender is considered a great stress and pain reliever. Certain cultures and regions, such as Persia, ancient Greece, and Rome, they actually believe that lavender can purify the mind and the body. So some of the ailments lavender is used to treat are anxiety, insomnia, depression, headaches, nausea, and hair loss. And at this point in the presentation, I'm going to transition over to Bree, and she'll take us through the next few slides. Yeah, okay.
All right. We're just having some technical difficulties. So the purpose of a code lavender, so like Renee talked about, it is designed to be a sort of crisis debriefing and trauma support. So we're going to get into some of the details of stress and what the program is ultimately what we think that it would be helpful with. But when a situation happens on the unit, or maybe you've had something happen traumatic at home, it doesn't just have to be within the workplace. It's a response that anyone can initiate, and a team can come and provide you that real-time crisis debriefing and trauma support. It's also there are studies that show that it's supposed to be a pressure relief for caregivers. So if you're working a 12-hour shift, and we're constantly under the stress and pressure those 12 hours, if we could have a dedicated 10 or 15-minute window where you can have some relief for that, where you feel safe, where you can express what's bothering you, it can provide you kind of a respite. And then there's other research articles that talk about it as being sort of a psychological band-aid or circuit breaker. So it cuts off that stress in acute situations. Even though you will have to walk back into the stress, it doesn't completely alleviate it. And I really liked the description of it being a psychological band-aid for a couple of reasons. So when I first read that, I was thinking to myself, when I typically think of a band-aid, or even, hear the term psychological band-aid, to me, that just sounds like a really superficial kind of offering, like that doesn't seem like it would be that helpful. But the more I learned about Code Lavender and the more I read, I was able to wrap my mind around it with, going back to medicine and thinking about, okay, the difference between a band-aid and sutures. So when you think about that, so we've got our nice visuals up here. When you have an injury or a wound that may require sutures, you oftentimes will have a Band-Aid or Steri-Strip that's placed over it until you can get the care that you actually need. So to me, the Code Lavender is kind of the same way as a Band-Aid. So it's not meant to replace talk therapy, cognitive behavioral therapy. It's not meant to, try to prevent medication, if you take medication to help you with stress. But it's just another tool for you to have in your tool belt to address stress when you're on the job. So I was telling Renee, I have a 7-year-old, but when he was 2, he of course fell, and he had a really bad laceration by his right eye. And so we had to go to Children's Healthcare of Atlanta, and he needed sutures. But while we were waiting, they did put some Steri-Strips over it. And I was telling Renee, and like, that's what Code Lavender is. So just because, maybe my stress does need something a little bit more serious than a Band-Aid, this is still helpful in the moment. So, the Steri-Strip or the Band-Aids keep the wound from getting infected, from getting worse. So think of Code Lavender along those terms. So it's not meant to replace therapy or something that's more intensive to help alleviate and eliminate stress. So when we talk about stress, I think that it's really important that we understand, the stress spectrum, and then also how it relates to compassion fatigue, as well as nurse burnout, when we think about Code Lavender programs, because really understanding how this is affecting our profession, I think it will help us to, wrap our minds around, like, we really are at a place that we need to start thinking innovatively and figuring out some solutions for our profession, because we are under so much stress. So when you look at the stress spectrum, we know we have 3 kind of levels of stress. So we have that acute stress, which is driven by your, incidents. So, Renee's situation that she described to us at the beginning, when you have a patient who codes, that's an acute situation. There's an exact start and stop to when that occurs. And then you have the subacute, which is, really the effects of multiple acute stressors that occur in a set amount of time. So maybe like a challenging shift. So you had a patient code, you also had a patient who needed to advance to a higher level of care. Maybe you had a bad interaction with a coworker or a provider. So just those acute incidences that add up throughout the day, that creates that subacute stress, which then turns into that chronic stress. So this is where we're constantly having acute stress that's adding up to subacute, and then it turns into that chronic stress. So unfortunately, with the stress spectrum, just because you're experiencing one stage of stress doesn't mean that the others go away. Oftentimes, you guys are all well aware of this. We are under chronic stress while acute things are happening. So it's just stress compounded upon stress upon stress, which is where we start to see the effects of burnout and or also known as compassion fatigue. So we wanted to make sure we're kind of all on the same page and that we really understand when we use the term burnout, because it is used a lot today, and especially after the year of a pandemic, we are hearing the term burnout and compassion fatigue. We're hearing those a lot, and do we really know what it means? So we looked at Christina Maslock. She has a burnout inventory. That's it's a tested inventory that you can take, and it measures three different things. So it measures your emotional exhaustion, so how you feel overextended by your job. And then it also measures inefficacy, which is defined as, do you feel like you're doing a good job? Do you feel like you're competent and that you're prepared to carry out and handle those acute stressors that are occurring? And then this concept of detachment. Are you starting to feel like your patients aren't actually people? Maybe they're just to-dos, or they're, things that are getting in your way and causing stress. So when I look at these and I think about, my experience as a nurse, I think, emotional exhaustion, that's not that scary. We've all been there. We all feel, overextended by our jobs at times. And even, in efficacy, I can think, okay, well, there's days that maybe I don't feel like I'm doing as good of a job as I could or as I should. What's really scary to me is when you have those two, the emotional exhaustion and efficacy, and then you throw in detachment. So I feel overextended. I don't feel like I'm really making a difference, and I'm capable to carry out my job. And then I'm also really not connecting with people on that human level. I'm starting to see them as, tasks or just, to-dos throughout my day. To me, that's when it gets really scary, especially in patient care. So it's important that, we are looking at all three of these, and that this is what we're thinking about when we're talking about Code Lavender programs, because this concept of burnout, it's becoming so prevalent, and it's been around for decades. I mean, we know, like the term was coined back in the 70s, and and it just continues to get worse. And I think that the public's becoming more aware of it as well. But what does that mean for us as a profession? So one of the things I wanted to share, you may have seen this recently, the American Nurses Association, they published their results from a 1-year survey, and they looked at data from about 22,000, a little over 22,000 nurses. And they asked them a series of questions, just kind of like a check-in, like after the pandemic, like, how are you feeling after this year? So if you look at this graph here, you can see the experiences and feelings that are red are negative, the blue are positives. So just knowing the colors, what really stands out is all the red. So we have, over half of nurses saying that they feel exhausted. They feel overwhelmed. They're feeling irritable. They're unable to relax. my work has meaning. It's great. 32% are saying that they feel like their work has meaning. But what does that mean for the other 70%? Does that mean that we don't feel like our work has meaning? So I think this is a great real-time survey that's showing our profession, we're exhausted. Our nurses, if we're not burned out, we're well on our way. And so a program like Code Lavender's, again, we don't think it's the silver bullet, but it's just something else that facilities and organizations can do to help support their staff. And then another question I thought was good to pull from this survey was, have you sought professional mental health support? And what was really interesting to me about this is that despite all of the negative feelings that nurses are reporting, that over half feel like they don't really need mental health support. Or what was even scarier is that 36% felt like they should be able to manage their stress on their own. And that goes back to Renee at the beginning of this presentation when she described healthcare as this stoic culture that we're taught from the very beginning. I can remember sitting in nursing school and being told by my professors, if you just have to deal, you don't have time to be sad, you don't have time to be exhausted, this is what you signed up for. And so that's the persona that I take on when I go into work. And so it's really hard for healthcare workers to say, I think I need help. I think I need some type of emotional support that I'm lacking on the job. And so we don't want that. We want to, move our profession in the right direction. Again, we don't want to lose nurses. I mean, we're seeing that, and probably after this year, it will be more. 17% of nurses leave the profession altogether after the first year. And then the second year, that number doubles to 35%. So a little more than doubles. So with the nursing shortage, we just can't afford to lose nurses at that rate. So we've got to start thinking innovatively and figure out what is it that we can do to help support our nurses and our other healthcare staff. So what's the message? So if you are at an organization and you implement a Code Lavender, what is it portraying to your staff? And we think that number one is that we care. So it's a great way to show your staff that, I know this isn't going to fix all of the problems that you encounter day to day, but this is something tangible that we can put into place that can help. And we know that will help your quality of care when you're experiencing these stressful days. It's also, showing staff that their needs are important, that they matter, and that we also know that nurses and other healthcare workers, we're not exempt from needing support when we experience life-altering or tragic events. Even if it is with our patients, it's not as personally. When you think about a lot of the trauma that nurses witness, it's shocking that more of us aren't talking about the stress and the trauma, because the things that we see and the things we have to do, most people, that is not their typical day. And then in terms of resilience, I think this is a great message because we know the Joint Commission, July 2019, they sent out a brief about resiliency and how there's two components to resiliency. So you want to have resilient nurses, but then you also want to have a resilient organization, which means that your organization, in the face of adversity, when you encounter things that are not expected, i.e. a pandemic, you can rise to meet the challenge, and then you can also continue your day-to-day. So when we think about it in light of that, this is a great way, Code Lavender, to not just help your workers be resilient, but it's also a great way to create a resilient organization for your workers. And then lastly, there's a quote from Reverend Amy Green. She's the director of spiritual services with the Cleveland Clinic, which is one of the early facilities that launched this program. And she said, it's apparent when employees feel supported by the institution they work for. They experience less burnout, higher satisfaction, fewer call offs, and better interaction with patients. What Code Lavender and other holistic support services are showing us is that the whole patient, family, employee ecosystem is interdependent. And when one part of the whole is nourished and supported, all benefit. So again, it's fostering that culture of care in that whole patient, family, employee ecosystem, which we know ultimately, and that's why we're all here, because we want to care for patients and we want to take care of people.
Thank you, Bree. And thank you for highlighting just how significant the burnout rate is. It got me thinking, and I am now seeing a trend. Can we truly say, well, the pandemic exacerbated the burnout rate? Was it ever that high before? What I'm realizing is that a lot of organizations are now using more new nurses and less experienced nurses. And what I've found, even in my own facility, is that our new nurses, they just haven't been afforded the opportunity to fall in love with nursing. Why? Because the moment they hit the ground running, they're in that fight or flight mode. And we just don't have the support system in place. So definitely programs like Code Lavender can provide that support so we're able to give that astute patient care. So if your organization implements Code Lavender, who can call a Code Lavender? Anyone. Anyone can call a Code Lavender. That's the beauty about this program. It is not partial to certain individuals, and it is designed to serve all areas of healthcare. Next slide, please, Bree. Okay, so when to call a Code Lavender? So I did a verbal poll, a very small pool of nurses, and 6 out of 10 nurses said they would definitely use the program if they had an unexpected death of a patient. And 4 out of 10 nurses said if they had a difficult and overwhelming shift, which would be pretty much every day, because I can say for sure that there will be a nurse who will say, I have a difficult shift each shift. We did a worded poll, and that poll, even though it's not showing here, correlated the findings of the verbal poll. And 6 out of 10 nurses, or most of the nurses, said that an unexpected death of a patient and patient care, which falls into that difficult, overwhelming shift. Other reasons to call a Code Lavender: death of a team member or physician, a major trauma or code. And recently, the facility I work for, we experienced a major trauma. We had a patient who lost control of her vehicle, ran through the ER, and unfortunately killed someone. And that person was another patient waiting to be seen. And I know it was very traumatic for everyone involved. Um, Other reasons to call: when faced with a difficult ethical dilemma in patient care, or when a clinical mistake occur, or a pandemic. I think all of us can attest to that, right? I remember during the first wave, we were all so scared. We didn't know what to expect. We were isolated from our families. We were isolated from our friends, from our children. And we had to put on a brave face and enter our patient room. And we had to care for those patients effectively and put our own needs aside. And the third wave of the pandemic, my unit, unfortunately, was the only unit which had to be shut down because COVID ran rampant through the unit. And thank God we didn't sustain any fatalities, but the emotional distress that came with that, it's still there. It's that secondary victim, that PTSD that we sustain from it. And so there were many moments we wanted to call a Code Lavender if we had one in place. And another reason to call a Code Lavender: difficult encounters with patients, their families, or team members. Next slide, please, Bree. So who are our stakeholders? Who will make up the rapid response team? We have spiritual services, those are chaplains, employee assistance personnel, or house supervisors. Chaplains are normally trained in crisis response and critical incident stress debriefing. So they are considered our premier responders. They're expected to offer spiritual support and therapeutic support, prayer. Our house supervisors and our employee assistance personnel, they will require training. And for facilities who are not financially able to provide that training, they will be provided with a cheat sheet or guide to follow. And they will provide the therapeutic aspects of Code Lavender, such as music therapy, meditation, therapeutic touch, escalation to counseling services, and of course, the follow-up care. Next slides, please, Bree. So the Code Lavender process usually occurs when a team member is identified to be in need of an emotional support or debriefing. And of course, like I said before, any member of the team can place that call. And usually the call will go through to the operator or to a care link center if your facility, have a care link center. And they will connect that individual to a member of the response team who will just take a brief description of the situation, and then the response team will respond to the individual or the individual's unit within 15 to 30 minutes and provide or take that person to a sacred space, which is usually pre-established, such as the chapel or a manager's office, a respite room or a break room. And usually the sacred space is used for the psychological debriefing. The individual receiving support is allowed to be away from that patient care setting for up to a maximum of 30 minutes or more, depending on the situation. And then, of course, the Code Lavender team will use that mind, body, soul psychological reboot for this individual. Next slide, please, Bree. So the Code Lavender interventions are staged interventions. The acknowledgement and comfort stage, usually nutrition services will be called to provide tea or water or snack just to provide the comfort that individual needs. The Code Lavender response team usually provide that one-on-one session with the individual. They'll introduce that stress relief measure which the individual will need, such as music therapy or meditation, deep breathing and relaxation exercises, prayer, guided imagery, therapeutic touch, and just a safe space to decompress and share discreetly. The visual cues stage, the Code Lavender responders will provide calming kits. And now the kits are usually lavender bags and they will contain a bunch of goodies. So you'll have like lavender LED votive candles, lavender sachets, lavender hand lotions, gift card, a stress relief handball, journals so the individual can journal or just write down emotions, positive affirmation cards, and you can put those on your badge, or chocolate, which we all love, and like lavender diffuser scents. So the individual gets that nice little comfort bag to go with. The additional support stage during the debriefing session, the response team will assess the need for further resources such as personal counseling. And I know we have a program at the facility where I'm from where it's called Caring for the Caregivers. And usually we can connect that individual to a counselor right away, immediately. They'll also continue the mental health assessment and provide the individual with the resources they may need to continue and follow up outpatient. The post-crisis follow-up stage, the Code Lavender response team will follow up with that individual, usually within a week of the debriefing session. And that's just to check in, to make sure the individual is doing okay, is feeling all right, and to get feedback on the debriefing session as well. Next slide, please, Bree. And now I'll turn the presentation over to Bree once again, and she'll take us through the next slides.
Thank you, Renee. So evidence supporting Code Lavender. So I think we've talked at length about, we know that there's a lot of evidence that just points to we have high rates of burnout. We have a lot of, we definitely have room for improvement. We have room for programs to help promote a resilient workforce and help caregivers and nurses move towards being more of a resilient worker. But then we also have some data from some of the facilities that have actually implemented this program. And what the Cleveland Clinic found is they just had astounding success
Yeah.
when they implemented the Code Lavender in 2008. So they found that 99% of their employees said that it exceeded their expectations, and that 98% would recommend the program to others to implement at their hospital. There's another hospital called Keck Medical Center. In 2015, when they first implemented the Code Lavender program, in that first month, they had 21 Code Lavender calls, which I think is really, that's a pretty significant amount, I think, for a new program. So there's evidence that supports Code Lavender, and I think it will be exciting if we have more organizations that implement similar programs, even if they want to call it something else, because that a lot of health systems like to have their own spin on things. But to see the data that will be published, and to see some of these surveys that are sent out by American Nurses Association and other organizations, do we see trends in burnout and turnover? Do we see that they actually start to decline the more we implement programs similar to this? And then I think it's also important to just consider potential barriers, not to be negative when you go into a new program, but I think it's always helpful to anticipate what roadblocks you might hit so that you can think about, okay, how are we going to overcome this if and when it does happen? And so obviously, number one would be low call volume. So if you are not getting a lot of calls based on fear. So again, we know, especially from just historically, nursing, healthcare, for ourselves, we're very stoic. We don't expect that from our patients, but we do expect that with ourselves and with our peers. So because of that stigma, we may see that people are not inspired to actually say that, hey, I would like to call a Code Lavender, or I'd like to access this resource. And then they, may also just need more education about what the program means. And it doesn't, maybe you work on a unit where you don't have a lot of codes, but that doesn't mean that you don't have a lot of acute stress that occurs and a need to call a Code Lavender. Indifference, I mean, that is, an enemy to lots of things. Probably every new rollout that you have in a hospital or an organization, if your workers are indifferent to it, the success tends to be stymied. So, it's important to not only educate staff about the program and implement the program, but allow your staff to be a part of creating the program. So get their buy-in by letting them develop what that program looks like for your organization. I know Renee can speak to this because she runs the task force at her facility for Code Lavender. And I know that in the past, I've been part of task force, with hourly rounding and things like that. And you could always tell, not that you got 100% buy-in, but you definitely had more of your team members buying into the program and excited about it because they feel like it's something that they helped to create. And then the lack of dedicated response team. So, if your stakeholders, if you have one chaplain for an entire facility, it's probably not realistic that they would be available, because if, patients have needs and their families have needs, that obviously comes first. So, sometimes you may have to get creative in who those responders are. When you think about getting the staff buy-in, we all have that nurse or that person that we like to work with on our shift because they're a good listener, they always have great advice, or they just have this kind of calming presence about them. If you have people like that that want to be part of the response team, maybe they're not that premier, responder like Renee mentioned earlier, they're not like a trained chaplain, but they have some proclivity towards providing that emotional support and just listening and helping others. Let them be part of it. So there's no hard rule as to who the response team can be. And then obviously, if the code team fails to respond or follow up, then the program is not going to be successful. So you want to make sure that if your staff is brave enough to make that call and say this is a need I have, you want to make sure that your resources can respond to that need so that you have a thriving program. And so we'll leave you with one last thought from Plato. And just, when we think about the mind and the body and the soul and wellness, I think this is a great way to wrap it up, that you ought not attempt to cure the body without the soul, for the part can never be well unless the whole is well. And that's all we have for you.
Thank
We'll
you
open it up
so
to
much,
questions.
everyone. Yes, please. This is an interactive session, and we would love to hear from everyone.
So I don't want to dominate this, but it's great. What you're doing is great.
Thank you, Dr. Gray.
From a psychological point of view, I mean, this is really important. And I think there's a couple things here that you've identified from a different discipline that psychology has been dealing with for a little while that I think is noteworthy. First of all, cognitive load. Cognitive load, there's a fair amount of research on cognitive load. And I'm not sure that everybody understands what cognitive load means. And each individual person has their own threshold of cognitive load. And to use nursing as an example, cognitive load exceeding an individual's cognitive load has been identified as the premier reason for medication errors with nurses. That when you exceed a person's load capability, errors occur. And so when you put cognitive load with emotional load, right, you have a beast. And in cognitive emotional psychology, there's a thing called caregiver strain. And I think it's very similar to what you're talking about. And in caregiver strain, and there are some actually some instruments that actually can measure a person's caregiver strain. And I would strongly suggest that you kind of dabble over there. And it's not an acute situation, which a lot of what you were talking about was acute, but most of this stuff is dynamic. In other words, you have a fight with your boyfriend or girlfriend or partner, and it's consuming you. That affects your emotional and cognitive load. So that would be something to think about, and I'd be more than happy to talk to you later about that. But what you're talking about is really a caregiver culture, and that's people don't like to talk about my limitations, because my limitations mean that I'm not as good as everybody else. So there's a culture of exclusion when it comes to that. So that's another thing that might be something to consider with what you're doing. Um, there's a couple of other things. Therapy. You know, I've been doing this for 35 years, and I can tell you that most therapists and most psychologists and psychiatrists are completely inadequate to deal with this. So when it comes to a point where a nurse says, I'm having a hard time, going to traditional therapy is going to be inadequate, and they're going to feel like it doesn't work. So I would strongly urge you to, kind of spend a little time with what that looks like when you say to someone that they need some mental health intervention, because most of the folks that you would be referring to have no idea
Mm.
what a person in battlefield conditions, because that's what you're talking about.
Yeah.
You're talking about battlefield conditions, life and death, and attaching to people that you find, interesting, that are going to die.
Yeah.
Right? That's a very difficult thing for any therapist to understand, because on the mental health side, most therapists don't have bad outcomes.
Right.
Right? So if they make a mistake in therapy, it doesn't result in death usually, right? So just spend some time thinking about that. Stress is also cumulative. It adds up, and so looking at strain as a cumulative event as opposed to an acute event, might be helpful in the ongoing evolution of lavender, if you want to keep that term, right? Lavender plus 2 or lavender plus or
Right. Right.
however you do it. The other thing is, I worked with the Pentagon on a project years ago with post-traumatic stress syndrome about, combatants. And I asked them, how do they build resiliency? How do you build a resilient combatant?
Hmm.
And they said, well, they have live fire and all these kind of things that they have to go underneath, razor wire and everything like that. But my friends who were in Vietnam, they told me the biggest problem they had was the smell of death.
Mm. Mm.
And so I said, do you put dead cows out there for them to smell, before they go into combat? Well, no, we couldn't do it. So how do you build resiliency in training programs? Right? Because that's really the issue here.
Yes.
Right?
Agreed.
I mean, people can absorb an enormous amount of strain if they're prepared.
Yeah.
So anyway, that's another thought. And the other thing that I have to say from a systems standpoint, the Joint Commission would be really, really interested in what you're doing.
Oh.
Right? They would be really, it would be something that they would really like to look at. And the only other thing I have to say about it is, to get a little more scientific with measurement and methodology. You could have something, more than just anecdotal, information that to kind of drill down on, some measurement issues. But this is wonderful. I'm glad I got invited. I don't know why I got invited.
Thank you, Dr. Ray.
I asked Sanderson why I was invited. She had no idea why I was invited. But I'm really glad I was invited.
All that feedback that we need.
Yes. we appreciate and welcome that feedback, Dr. Ray. Really amazing. Yes. Yes. Thank you for, the situations you described. You are absolutely 110% correct. Yes. All right.
Okay.
Sorry. I would just like to say that you guys did a fantastic job in your presentation, really
Thank you,
hitting
Sheila.
all of the areas that, because like the questions that I prepared beforehand pretty much were answered during your presentation. So that was great. And, just the thought that I kind of had that goes with Dr. Bray's thought was, as I'm listening, I'm thinking an interesting time point to look at would be after an EMR implementation. Because that additional cognitive load that we put on people, it really reduces their ability to deal with everything else that's happening. And so that would be a very interesting time point to see, like, do your calls go up? What is the response?
Yes.
As well as, just sitting here with that working not in acute care, but how would this work where I'm at?
Yeah.
So that's also just a really interesting thought-provoking thing is, this is applicable in more than just acute care.
Yes.
Because it happens in any setting that you're interacting with people and you're caring for people. So yeah, really interested to see where this goes.
Yes.
Fantastic.
Thank you, Sheila. And you're absolutely right. You see, and it's a growing field. Unfortunately, it's not as much as it's nationally known, it's not popular in a lot of systems. And I am not sure why that is, possibly cost. But it doesn't have to be costly if you're using internal members. But for some, they would prefer that training for their caregivers, to prevent their burnout. So I agree, in every setting, it definitely can apply.
Can I say something? I
Sure.
am a mental health nurse. I've been in forensic psychiatry for 22 years.
Yeah.
And we have used, it's not called Lavender, but we use that on a daily basis.
Yeah.
And we go further than that by having what we call supervision.
Mm.
So my supervisors supervise me. I supervise others that under me. It's a weekly thing because you have to let out all that, whatever you're taking around with you.
Yes.
And it goes right down to the housekeepers, the individuals in the kitchen, because you want people to talk about what's bothering them. And I get this from my family sometimes. They're like, I don't know, you can work with those criminals all this time.
Right.
And I'm like, well, I'm okay with it because I have supervision and we huddle a lot.
Okay.
When something happens on one of the units, you get together. When you realize something's going on, you huddle, you bring people together to identify what you've seen and what we think is gonna go on. So this is something that we have been doing. And I don't feel burnout. We just went through the whole pandemic stuff, and we were fortunate. In my hospital, we have 300 patients, and only 6 had the COVID. So we were fortunate.
Wow.
We were fortunate.
Wow.
We had more staff having the COVID. I'm on the grounds of 500 something patients.
Wow.
And this is something that we do. And we do have a crisis team also, as you said, made up of the chaplain. And we just have a lot of individuals, and they respond to anything we have in the hospital. They respond statewide. They even go out of state and respond when there's a crisis. So it's very important that we have support.
Yes.
I remember going to my BSN program, and I was petrified. They just said, jump right in there and do it.
Yes.
I never thought I'll ever be a mental health nurse. Because when I went into mental health, I'm like, do I need to do this?
Right.
But I came out and tried quite a bit. And I love what I do in mental health. So that is very, very important for us to talk about things that's bothering us. But we're a society that does not speak about our stressors.
Yes.
And we take it into work. So you're doing a great job.
Thank you. And you just highlighted the point that Dr. Ray presented, where it starts from, like you said, when the BSN program, it's like, okay, you're out there now, bye. And that's what I'm realizing. A lot of new nurses, I have a lot of new nurses on my unit. And I'm telling you, it's almost as if we're trying to prepare them when they should have been prepared. prior to starting, and so it's difficult because, like Dr. Ray says, the errors are, they're through the roof because of that, and because there's no support, we can't seem to get it under control. So thank you so much for sharing that.
I also would like to say thank you so much for an excellent presentation. There were several takeaways that I have. I actually work in long-term care, so I agree with the young lady that stated about it's not just an acute care setting. My company actually did a different version of it, and I have something to take back to them now, because I think that as an organization, we started with the extraneous factors, building it from an outside source, looking at those things that we may be stressed about, but having outside consultants and things to be available for us in our life program. Now, I think that we can take it and look at it from a different perspective and look internally to see those individuals that are internal and that are able to identify or help us to identify, so that we can channel them to our support system in Life Matters. Because just as individuals have stated previously, is that I think that my sister works in mental health, and she has a shirt that says "Stop the Shame," because sometimes even in various cultures, it's not. In my culture, we just really don't, and in my family, it could be even family oriented, that you just kind of shun when there are mental health issues. We don't want to deal with them or want to talk about them. And we need to, stop the shame and get to the root cause. So you've given us an avenue, I think, to address those things and to not feel, because when you look at it from Code Lavender perspective and understand the benefits to lavender, and when it's given to us in that manner, I think that helps us to present it in a different manner to our colleagues, to our family members, so they don't feel shame. And I think that's it's great. So thank you so much for the insight on this process.
Thank you, Deborah. Appreciate your feedback.
Renee and Bree, this is Deborah Illig. I know we've only got 2 or 3 minutes left in the session this evening, but I wanted to ask how you accommodate diversity, how we approach inclusion, certainly recognizing that everything that you've laid out tonight could sit as relevant in just about any scenario, but what efforts have you made to be very mindful of how those dynamics play into very sensitive situations as well?
Yeah, and thank you, Deborah, for that question. I know at my facility, I'm spearheading that task force to try and get this implemented. But like Bree said, with that buy-in, it has to reflect the entire organization too. Coming from that aspect of it, then when the call is made, we're able to handle whoever those responders are. People can identify themselves or see themselves in that responder. And that's important. That is key, because there's that aspect of shame. There's that aspect. I'm not going to talk to someone who won't understand my culture. So yes, that response team, it starts from the get-go. And that's what at my facility we're trying to do, is make that task force reflective of the entire organization, from the leadership down, and the response team the same way. That way nurses from all cultures can feel comfortable speaking about, issues that may be affecting them culturally as well.
Wonderful. Thank you so much.
You're welcome.
I don't think there's really anything to add to that, but that, I think, Renee, you answered that beautifully. And that, with any program, you kind of have the framework of this is what it looks like. And then, you diversify it by ensuring that the people that implement it are a diverse crowd, which I think is why, with any program, you want to be leery to make sure it's not, coming from the leadership and going down, that it's your bedside, if it's in nursing, it's your bedside nurses, and that task force is reflective of your unit. And like Renee said, it's that will help you have a successful program. And I think also, if you have like a large organization like where Renee is coming from, it may not be like one task force for the entire hospital. You know, if you have a women's center, they may have their own task, you know, Code Lavender response,
Right.
because obviously they have different kind of acute trauma and stressors that are occurring versus like an ICU or an ER, which is, you know, that even just not just culturally, the temperament of, you know, nurses who work in one area versus the other, it's so different. And so I think that it's just using it as a framework, and then you let the end users really create it for what they want it to be.
Thank you so much.
Thank you.
Well, thank you very much, Renee Brand, Bree Becker, Code Lavender, not a typical code. Phenomenal presentation, really great conversations, and just can't thank you enough. It was excellent.
Thank you so much,
Thank
Dr.
you guys for being
Thank
here.
Thank you, everyone.
Thank you.
Bye.
Bye.
Bye.